Good day, everyone. I am Dr. Denny, and I will be discussing today another common specimen that is received in the laboratory. We call this serous fluid. So these are the objectives for this lecture. So your serous body cavities are those which surround various organs. In other words, these cavities enclose, okay, they enclose certain organs. So for example, there is actually a space that is enclosing the heart, and we call it pericardial. Okay, pericardial cavity. And the space, the cavity surrounding the lungs is what we call pleural cavity. And that space surrounding the your abdominal contents or organs is what we call a peritoneal cavity. And these cavity is usually lined by membranes. Okay, so serous membranes. Now, your serous membranes may be parietal or may be visceral. Those directly lining the organ, okay, we call it visceral, okay, visceral membrane. And after the visceral membrane, so supposing, okay, supposing you have, supposing this is your heart now, supposing this is your heart, okay, the heart is lined by a membrane, okay, and this membrane directly enclosing the heart is what we call, or any of these organs is what we call the visceral membrane. And after the visceral membrane, there is actually a space, okay? A space, a very small space there before another membrane will enclose it, okay? And this membrane, after that space, is what we call the parietal membrane, parietal serous membrane. And the space in between the visceral and the parietal membrane, the space here, the spaces here, what we call now your body cavities. Now, these body cavities are filled with fluid, okay? They are filled with fluid that is to allow a sliding motion, a frictionless functioning of the organ. Otherwise, it would really be painful, no, if this area here is actually compressed because you don't have enough fluid. And that fluid in these cavities is what we call now serous, okay? Serous fluid. To continue, okay, your serous fluid is an ultrafiltrate of plasma and is usually maintained by pressure forces. Okay, you must remember this, no pressure forces. I have a separate slide on this. So these are the pressure forces which will actually determine the amount of serous fluid in these cavities. So you have osmotic pressure, colloidal osmotic pressure. This is usually brought about by proteins, okay? Proteins. And then your capillary hydrostatic pressure, usually this is brought about by a fluid pressure. And then same goes with your capillary colloidal osmotic pressure brought about by proteins and tissue hydrostatic pressure due to the fluid, no pressure fluid in the surrounding area of these body cavities. And there are instances wherein there is so much, okay, because each fluid, okay, has a certain level or amount that should be maintained. And in cases wherein there is an increased level of these fluids, we call it now effusion. If the effusion is in the heart, the serous cavity of the heart, we call it pericardial effusion. If the effusion, this excess serous fluid is found in the spaces surrounding the lungs, we call it pleural effusion. And if these effusion, okay, excess amount of your serous fluid is found in the serous membranes lining your abdominal organs, we call it peritoneal effusion. Now, I mentioned that there are actually diseases associated with so much accumulation of the serous fluid, okay, this effusion. In other words, when you hear the word effusion, you must associate this with a particular pathological process, such as all of these, okay? So later I'll teach you also how to differentiate, transudate, and exudate, but what my point now here is just to show you that there are a variety of conditions associated with an elevated accumulation of your serous fluid in the different serous body cavities. So for example, the transudative effusion in the pericardium, the pericardial cavity is associated with congestive heart failure, in cirrhosis most likely associated with peritoneal effusion, but there are instances wherein you have portal hypertension also. It may also cause accumulation of fluid in the pericardial cavity. Okay. Then I mentioned a while ago that there are actually forces that will maintain a normal volume of the serous fluid in the different serous body cavities. Okay, serous body cavities. And what are those forces again? The capillary hydrostatic pressure, oncotic pressure, um, capillary oncotic pressure, and another is tissue. Okay, tissue oncotic and hydrostatic pressure. Now, any abnormalities of those maintaining pressures, okay, would actually result to formation of effusions or an excess accumulation of your serous fluid in the different serous body cavities. For example, you have increased capillary hydrostatic pressure, which is usually associated with congestive heart failure, salt and fluid retention, and among others. Okay. So this is what I've been telling you, that there are four major forces maintaining a correct volume, normal volume of your serous fluids in the serous body cavities. So we have this what we call oncotic pressure. And again, oncotic pressure, I would like to put emphasis that this is brought about by proteins. Now, the main action of your oncotic pressure is to actually pull fluid. They pull fluid from the interstitial space or from the cavity towards the blood vessel. So you see here, the arrow goes towards the vessel, okay, capillaries. So it pulls the fluids. If there is a fluid here, you have normal levels of proteins. There is a pulling pressure of whatever fluid that is in here, okay, through the action of your oncotic pressure. Now, hydrostatic pressures, on the other hand, would actually cause a filtration or sieving mechanism, no? Because the pressure is actually going into the cavity, such that fluid now from the blood vessel, because you have increased hydrostatic pressure, the action there would be it will actually cause a leaking of the fluid into the space. And this interaction of the opposing pressures of oncotic and hydrostatic pressure would actually maintain the normal level of your serous fluid. So serous fluids are collected using needle aspiration. Okay, so I have tried these two, thoracentesis and paracentesis. When I was an intern, a medical intern, I haven't actually seen pericardiocentesis, but this is these are delicate procedure because one mistake, remember, this space here is really a potential space, no, very narrow, and one mistake would mean hitting the organ, right? So if the needle aspiration is done to collect pleural fluid, we call it thoracynthesis. If the needle aspiration is done to collect pericardial fluid, we call it pericardiocentesis. And if peritoneal fluid is collected, we call it parasynthesis. Now, EDTA tube is used for cell counts and differential counts. So just like any other body fluids, we also do cell counts and differential counting of your serous fluid because a variation, okay, presence or absence of a particular cell or variation of cell value, cell count values would actually tell us a specific pathology that is present, that might be present or causing the effusion. Sterile heparinized evacuated tubes are used for micro testing and cytology, okay? And chemistry tests may be collected using plain tubes, meaning tubes containing tubes which do not contain any anticoagulant, or you can actually collect using heparinized tubes. Now take note, since usually these chemistry tests, chemistry analytes that we collect, okay, chemistry tests that we perform using the collected serous fluid are actually compared to analytes found in the plasma, because remember I mentioned that your serous fluids are actually an ultrafiltrate of your plasma, such that simultaneously, okay, you should also do a chemical test, chemistry test using your own blood sample. So whatever results you got here, chemistry results you got here using the serous fluid is compared to the chemistry test using the blood sample of the patient. So these are the routine laboratory tests done for serous fluids. We have macroscopic examination, more or less just like urine, no? But we have specialized tests that is only done using serous fluid. So macroscopic examination, chemical testing, microscopic examination, and microbiological examination. We'll discuss this one by one. So let's start with macroscopic examination. So normally your serous fluids they resemble the serum. So that's why you need, okay, being an ultrafiltrate of your plasma, your blood, you really need to collect a separate specimen using your blood sample, because whatever analytes that you get, okay, from chemistry testing, if your serous body fluids are more or less likely resembling those analytes found normally in the blood circulation. So the normal serous fluid is clear and pale yellow. However, certain color, okay, of your serous fluid may actually denote something. For example, a reddish or sanguinous, serosanguinous specimens may indicate that there is an active hemorrhage of the organ associated with that fluid, or it may also appear in traumatic taps. So for example, you have hit any vein or any vessel when you did the procedure. Purulent specimen, meaning purulent, there is a presence of pus. And presence of pus would actually denote presence of WBC. So this is usually associated with infectious process. Remember, your WBCs are increased. Your WBCs are increased when there is an infection because they are the soldiers of the body, and being the soldiers of the body, they defend. Okay? They defend the body from these infectious microorganisms. And so they increase in number with, okay, with trying to eliminate this offending antigen or infectious agent. Milky fluids may contain chyle or pseudochyle. Cholesterol crystals, when present, contribute to golden green fluorescence, okay? And clotted specimens, usually if you've seen any clot, you report it because there is actually condition associated with clotted serous fluid. Now, this is table showing you the different causes, okay, the different pathologic conditions associated with each color appearance of your serous fluid. So again, I've mentioned a turbid or white or a purulent specimen would denote microbial infection. And bloody or sanguinous specimen would denote traumatic top or presence of hemorrhage. Milky for chylous and pseudochyle, and brown for amoebic liver abscess, and among others. So we differentiate again chyle from pseudochyle using the following criteria. So they both appear milky, but sometimes your pseudochyle may have a greenish tinge, and your chylous effusion is usually caused by leakage from the thoracic duct, whereas your pseudochyle would actually tell us a chronic inflammatory process happening. Okay? And other components, okay, other tests may be used to differentiate chyle from pseudochylous infusion. So, for example, presence of lymphocytes predominantly seen in chylous effusion, presence of cholesterol crystals in pseudochyle, and a higher level of triglycerides in chylous effusion. And remember, since your chyle is actually, you learned in chemistry first sem that chyle is actually carrying um, cholesterol, okay, such that a Sudan 3 staining, which is a cholesterol stain, would produce a positive reaction for chyle. So chyle, being marker of a chronic inflammation, does not carry um, does not have anything to do with carrying your cholesterol to the circulation, which is the function of your chylomicrons seen in the chyle. That's why your pseudochylous effusion would actually give us a weakly positive or negative, more or less negative, no common negative, rarely weakly positive for fat stain using sodium-free dye. So when the fluid is collected from pericardial cavity, okay, so these are the conditions associated with an abnormal appearing or abnormal looking pericardial serous fluid or pericardial fluid, such that a gross or bloody specimen would mean trauma. Remember, I told you, you must be careful because you don't want to hit any vein or any organ. Okay, so you may have hit cardiac, you may have hit any structure from the heart, or when the patient is taking an anticoagulant, the chances are there is actually a high risk for bleeding. That's why the serous fluid may look like bloody and a blood streak. Okay, pericardial serous fluid may be indicative of infection or malignancy. So it would actually differ from peritoneal fluid because a certain color may mean another pathologic condition associated with the organ lined by your peritoneum. So we have a green appearing serous fluid may be associated with disorders of the gallbladder or pancreas, and a turbid, okay? Turbid appearing peritoneal fluid may be associated with an infectious process, or a milky appearing fluid may be associated with trauma and lymphatic block. So let's go now to chemical testing. So the routine test, no, the most commonly performed chemistry tests for serous fluids are glucose, lactate, dehydrogenase, and protein. Because these three actually is used to categorize your fluid if it is a transudate or an exudate. Other tests, okay, additional tests may be performed, including alkaline phosphatase, ammonia amylase, bilirubin, among others, but these are not actually routinely performed. You may actually add, these are just addendum, supposing you are ruling in any other condition that may not be ruled out using these common tests. So how do we remember I mentioned that your chemistry test will differentiate transudate from an exudate. So how do they differ from each other? Usually your transudates appear clear, whereas your exudates are cloudy. Your fluid to serum protein ratio, remember I told you that simultaneously, you should be collecting also a blood sample from your patient. No, aside from the serous fluid that you have collected, you should also collect blood sample because remember, again, I'd like to put emphasis on this. Remember that your serous fluid is an ultrafiltrate of your plasma, meaning whatever analytes are found in your serous fluid may be likely more or less resemble those analytes found in the blood circulation. And so if you compare these two now, okay, you compare the values now more or less, they resemble each other, such that a fluid serum protein ratio of less than 0.5 is indicative of transudate. An exudate would have a larger value, more than 0.5. A fluid serum LD ratio is less than 0.6 or more than 0.06 for exudates. And we actually have this what we call Light's criteria. Light as in light, okay? Bright, no? Light. We have this what we call Light's criteria that will actually help us determine if the fluid that you have collected is an exudate. So any of these, okay, any of these criteria fulfilled will tell us that the fluid is exudate. Number one, what's the first criteria for Light's criteria? A fluid serum protein ratio of more than 0.5. Number two, a fluid serum LD ratio of more than 0.6. And the third criteria not seen in this table is an LDH, okay? An LDH, a serous fluid LDH level more than 2/3 of the serum upper limit, upper normal, upper limit normal level. So more than 2/3 LDH level in the serous fluid, compare it with the blood LDH. So any of those criteria, even just one, you could actually say that the fluid is an exudate. Again, what we call that criteria? Light's criteria. Presence of large amounts of WBCs, particularly more than 1,000 cells per UL, is associated with an exudate. Clotting possible with exudates, and more cholesterol and higher pleural fluid serum cholesterol ratio is seen in exudates. In higher pleural fluid bilirubin ratio is seen in exudates, and isaag. No? Usually the saag is used when is used to compute, usually computed or reported when the fluid in question is a peritoneal fluid. You don't use saag in pericardial and pleural fluid, no? Only in peritoneal fluid. So how do you memorize this? Very easy. More or less higher values are seen in exudates except for saag, which is higher in transudate. Very easy. But again, very important to remember, okay? Kahit saan kayo pumunta, kahit mag-medicine, you will still be asked about the Light's criteria. And that's actually a high yield question for the board examination. So this is an algorithm, okay, that we usually follow when we physicians collect fluid and we want to rule in something. So we remember I mentioned, no, we classify first if the fluid is an exudate or a transudate. And again, what is that criteria that must be fulfilled for a certain fluid to be classified as an exudate? The Light's criteria. And I've mentioned this already. These are the criteria of your, these are the Light's criteria. Just one, no, even one result, okay, pointing to an exudate will confirm that the fluid is actually an exudate. So any positive, even just one. So if yes, it's an exudate, or if not, it's a transudate. Then you can perform, again, I mentioned supportive, okay, supportive or addendum test, which I have mentioned a while ago. And any abnormalities of these tests now will tell us the etiology of that particular effusion. So if there is an elevated amylase level, may be seen in pancreatitis, or if there is adenosine deaminase level, increased adenosine deaminase level, coupled with an abnormal WBC count or differential count with lymphocytosis, it may be associated with tuberculosis. Okay, take note, high ADA levels, adenosine deaminase levels, plus lymphocytosis on diff count for serous, not the blood sample, diff count for serous fluid, is lymphocytosis would maybe you can rule in tuberculosis. Okay, and remember, your TB is not just found in the lungs; it may actually spread in any parts of the body. Such that TB, when disseminated now, okay, we call it disseminated TB or miliary TB. Or if the cells that are predominant, okay, still ADA of more than 40 microliters, but this time in the differential count, the cells now which are elevated are granulocytes. So you learned in HEMA what are granulocytes. These are actually cells containing granules in the cytoplasm. Okay? So if you see a higher level of granulocytes, it may be indicative of a bacterial infection. Or you can actually determine the pH. If the pH is less than 7.2, there may be a need for chest tube insertion. Or if the pH is less than 6.0, there might be an esophageal rupture. So these are the specific chemical tests usually done for pleural fluid. Okay? We have glucose, lactate, triglyceride pH, ADA, and amylase. Again, increased ADA of more than 40 plus lymphocytosis associated with TB. Okay? And also malignancies. That's why you run tests. Okay, you do not just run a single test. Your serous fluid testing, laboratory testing is actually comprised of a battery of tests, many tests. So for peritoneal fluid, you actually have different sets of laboratory tests. So you need to memorize these tests for examination purposes. So let's go now to microscopic examination. Okay. Just like your urinalysis, we also perform microscopic testing because we can actually see cells, cellular components that might indicate something. Okay, so for example, if you've seen red blood cells, you can tell that the serous fluid, may be having a certain pathologic process. It was actually produced because of a certain pathologic process, because red blood cells are not normally seen in your serous fluid. Or a presence of WBCs will tell us something. Remember, lymphocytosis associated with TB, granulocytosis associated with bacterial infection, and among others. And mesothelial cells are actually the normal cells that line your serous cavities, and you can actually see this normal body fluids, serous fluids. And some effusions may be caused by malignancy or neoplasms or cancer. That's why we do microscopic examination, because these malignant cells may be seen under the microscope, especially when you stain. You do cytology and then you stain. Microorganisms also may be seen when you do right staining. So these are the significant cells seen in pleural fluid. Okay? So neutrophils increase in the following condition: lymphocytes in viral infection or TB. Mesothelial cells are actually normal cells, but the decreased levels or amount of mesothelial cells are associated with TB. Plasma cells seen in TB and malignant cells seen in cancer. Another set of cells in pericardial fluid. Okay? Because if you see malignant cells, this may be associated with metastatic carcinoma or increased level of granulocytes, okay, may be associated with an infectious process such as your endocarditis. And if you do gram stain and culture, you can actually isolate these infectious agent causing the endocarditis. And then you have again, what's the common? Let's see if you can recall your micro lessons. What's the most common bacteria causing infective endocarditis? Infective endocarditis for an immunocompetent IV drug user. What's the most common? Very good, Staphylococcus aureus. Then we can also do acid fast staining for tubercular. For peritoneal fluid testing, we actually also have different sets of values and different associated conditions with a particular cell count. So I mentioned that we can also observe malignant cells in your fluid, and your malignant cells, your cancer cells actually may look like this. Okay, so usually they are larger with bigger nucleus, okay, almost occupying the entire cytoplasm, thus the high NC ratio, with an irregularly distributed chromatin. And these malignant cells usually comes in different sizes and shape, and presence of nucleoli would mean that these cells are actively dividing, okay? And since the chromatin is irregularly distributed, okay? More or less see hyperchromatic nucleoli and giant cells. They are large cells, as I've mentioned, having high NC ratio, or maybe these cells may have more than one nucleus, thus the multinucleation here. Okay, nuclear and cytoplasmic molding, vacuolated cytoplasm, mucin production, and cellular crowding or phagocytosis. So lastly, we have microbiologic examination. So again, as I've told you, usually do this if you rule in a certain infectious process. That is, you want to isolate the causative agent. Okay? And just like normal specimens in the received in the microbiology laboratory, you do some staining, no? If you rule in acid fast, so you do a TB. If you rule in TB, you can do acid fast staining, or bacteria, you can do gram staining. You can also do right staining. So these are the most common bacteria associated with your effusion. Okay, so staph and MTB for plural, Haemophilus influenzae and MTB for pericardial, Escherichia coli and pneumococci for peritoneal. So that ends my lecture for peritoneal serous fluid. I hope you have learned something today. Very short and very easy. So I will be expecting you will be getting high scores. It's time for you to bawi, guys. You may not have passed many exams in the midterms. And if you think that you are failing, okay, there is actually still a chance, okay, because still have the remaining 2/3 of your grades, no? Pre-final and your finals. So you do not quit, just continue, no? Laban lang, guys. When you feel like quitting, think about why you started. You've come this far, there's no point going back. Again, thank you very much. If you have questions, feel free to email me anytime. Thank you, guys.